So hello and welcome everyone to our January MMS info session. These sessions are offered under the CMS Measures Management System contract led by Battelle. I am Kate Buchanan and I support the education outreach efforts on this project. Today's session is When the Journey is the Destination, tackling the complexities associated with diagnostic performance measurement, during which you'll hear from my colleague Jeff Geppert. Next slide. These info sessions are part of an ongoing effort to engage measure developers and other stakeholders in quality measurement topics, an effort that also includes a series of newsletters and bulletins along with special announcement emails, public webinars, and routine updates to the Measures Management System website. Next slide. So before I turn over to Jeff, I do want to cover a few housekeeping items. First, today's session is being recorded. Second, all participants will be muted during the call. We will have an opportunity for Q&A at the end of the call, during which we encourage you to enter questions into the chat feature. And so on this slide, you can see the chat feature is at the through the Q&A feature. So if you hit those three dots, the Q&A will pop up and you can ask questions. Finally, today's presentation slides are posted on the MMS website. I will also note that they are in the chat. So if you look in the chat, you will see a link for these slides. We will be posting referenced materials throughout the presentation using this chat function. So just wanted to let everyone know that you to keep a lookout on it. And if you're not seeing any materials in the chat function, please send us a question through Q&A and we can help. So with that, I am going to turn it over to Jeff.
Thank you, Kate. Thank you, everybody, for joining today. So we're going to talk about measuring diagnostic performance. As the title of the presentation kind of suggests, this is very much of a emerging area in terms of measurement. And so we're going to be kind of talking about why that is, why measuring diagnostic performance is a challenge, has been a challenge, will be a challenge. But then suggest some of the ways in which those challenges could potentially be addressed going forward. And so we'll talk just a little bit about kind of the background about diagnosis and quality, some of the recent publications that have been put out in this topic and are interesting for folks to look at and to read to provide some conceptual background. Again, kind of address some of the known challenges with measurement, but some of the emerging best practices that might help to address them and really sort of drive home this connection between measurement and quality improvement. Next slide. So it might seem a little bit strange, to start off by saying, that diagnosis is important. It would seem a little bit self-evident, and yet it's been an area and a topic that has received relatively less attention, particularly in the measurement space. So, diagnostic errors, diagnostic performance more generally, which could include an inaccurate diagnosis or a delayed diagnosis, happen in all settings, primary care, emergency departments, hospitals, and are much more common, according to the sort of the best estimates than one might expect. And the consequences can be pretty severe. It can lead to a lot of patient harm. It can certainly lead to quite a bit of psychological distress. It can increase costs both for the healthcare system and for the patient. And so there's a tremendous opportunity to improve the quality of diagnostic performance, to reduce harm, to enhance the patient experience, to mitigate the financial consequences. The other sort of important, obvious sort of connection but one that makes diagnostic performance measurement particularly challenging is, the sort of the obvious connection between diagnosis and treatment. If the, incorrect diagnosis is made, treatments that are either unnecessary or inappropriate or potentially harmful may be given to a patient, or necessary treatments might be delayed. So although there's been sort of a tremendous, emphasis and focus, certainly over the last 20 years on patient safety, the specific focus on addressing diagnostic performance has been limited, and we're going to look at some of the recent studies that have sought sort of to address that. Next slide. But we'll just sort of start off with a case study that was published by the Agency for Healthcare Research and Quality that looks at a really important area of diagnostic performance, which is, maternal morbidity and mortality. And this is a case study that looked at a particular circumstance of a complication that occurred immediately after childbirth. And we'll look at some of the lessons learned here, but I think this case study typifies a lot of the sort of the complexity and iterative nature of the diagnostic process, where, somewhat ambiguous signs and symptoms are presented, decisions are made, treatments are given, treatment responses are evaluated, and it's a very sort of iterative, complicated, process. And so, how does one think about measuring such a process that is so iterative and so potentially, complex? And the other thing to note about diagnosis is that, we think about sort of, broad stages of a person's journey, where, stage A is kind of when they're, relatively healthy and the focus is on wellness. Stage B, where they might have some signs and symptoms of particular conditions, but no structural change. Stage C, where there might be some structural change to an organ like a heart. There might be functional status changes, or, chronic conditions. And then stage D, where they're more in an end stage circumstance, a failure to rescue, or, a more rapid progression towards mortality. And diagnosis has a role to play in all four of those stages, both in wellness, stage B, stage C, and stage D. But I think the focus historically has been more on the stage A, kind of the screening type of activities. In stage C, where people have chronic conditions, but there's been less focus on this kind of stage B, where, they have more kind of amorphous stage signs and symptoms, and there's more of a sort of a process that needs to occur in order to identify, what the person is at risk for. And so a lot of the kind of newer emphasis and diagnosis is really on that kind of stage B stage. Next slide. But the case study identified several aspects of the process where there was an opportunity for improvement. The initial assessment of the patient's self-reported symptoms, the performance of diagnostic tests and the way that those tests were interpreted, how that information was followed up on, and what kind of treatments were tried, and then sort of response from a multidisciplinary team that would be, really necessary to sort of address this issue. So again, this case study really typifies a lot of the complexity issues. It's a team-based effort. It's an iterative effort. Often treatment is part of the diagnostic process. The patient is a key participant in this process. And so that's what we're sort of having to deal with and think about how to measure. Next slide. So again, measurement has a role to play here. There are multiple strategies by which one might try to improve diagnostic performance. There are quality improvement strategies and training and all sorts of things that one can do, but measurement, has a role to play. And those could be structure measures, they could be process measures, they could be outcome measures. The full gamut of sort of measurement tools that we have available to us. But really the goal is to try to increase the quantity and quality of measures of diagnostic performance that could be potentially available for use in programs. So that is kind of what our objective is to try to increase the availability of measures that could be used in accountability applications or other kinds of reporting applications. Next slide. So there's been three, there's lots of literature on this topic, but we wanted to sort of emphasize three reports that we'll kind of review today that have been informative to our thinking about how best to approach diagnostic performance measurement. So there's a really seminal report that was released in 2015 by IOM on improving diagnosis in healthcare that we'll look at in some detail. And this was really sort of a follow-up, to the earlier reports on medical error from IOM and quality from IOM. And really the emphasis was that they felt like this topic wasn't receiving the attention it deserves. And then kind of in response to that, AHRQ had some convenings and issued some reports that looked at some of the challenges and opportunities around diagnosis. And NQF as well convened some TEPs and did some environmental scans, came up with some recommendations for potential opportunities for measurement. Next slide. So one of the things that the IOM report did that was particularly helpful, I think, was they spent a lot of time sort of conceptualizing what is the issue, what is the kind of the process, what are we trying to sort of measure? And I think they came up with a very useful sort of conceptual framework, both to define what diagnostic performance is and the diagnostic process. So they sort of defined diagnostic error as both the failure to both establish an accurate and timely explanation of the patient's health problem. So accuracy is in there, timeliness is in there, explanation is in there. And then as part of that, they also count as a potential error in diagnostic performance is the inability to communicate that explanation to the patient. So it has both, activities on the clinician side and explaining the diagnostic explanation to the patient. So that patient piece is often sort of missing in a lot of the metrics that are under development for diagnostic performance, and there needs to be more of an emphasis on that. Next slide. So in addition to the definition, the IOM provides a sort of a conceptual mapping of the diagnostic process, which is very useful in several respects. One is that it really sort of emphasizes the complexity and iterative nature of this process. Again, it highlights the importance of patient engagement and care coordination in the process, and identifies potential opportunities for improvement. So one of the things I want to make sure we point out is at the beginning of the process is when the patient, experiences a health problem. So increasingly, that is becoming part of diagnosis. The patient often recognizes that they're experiencing a health problem outside of the brick and mortar of the healthcare system. And we've seen this particularly with COVID, where home testing and there's a lot of other areas where home testing is becoming increasingly important. There are mobile applications that, that are available for patients. And so instead of the diagnostic process starting, at the healthcare system, increasingly it's starting, before the patient engages with the healthcare system, and that's going to be increasingly part of the quality of the healthcare of the diagnostic process. The second part, is the more traditional, where the starts where the patient engages with the healthcare system. But here again, we've uh, it you know the ability of the patient to engage with the healthcare system involves access issues and equity issues, and so that is again a point where there's an opportunity for some measurement focus to ensure that patients have equal opportunity to engage with the healthcare system. And then the diagnostic process itself involves these three stages of gathering information, integrating and interpreting the information, and then using the information to establish a working diagnosis. And the emphasis is on working diagnosis to emphasize the uncertainty associated with the diagnosis and the fact that this is an iterative process. That working diagnosis is communicated to the patient. There's some treatment involved, but as we saw in our case study, often that treatment establishes new diagnostic information, which is then fed back into the process, and then it repeats. The outcomes of this process, which could potentially involve outcome measures or an accurate and timely diagnosis. That's what we want. But there also could be opportunities for improvement if there were errors or near misses. Next slide. So one of the things that is sort of striking about the IOM report is there's a lot of recommendations for improvements that are needed in order to improve the diagnostic performance. And I just want to emphasize, a few things that are, particularly relevant to measurement. So one is this process, that is very complicated and complex, and really demonstrates kind of this connection between diagnosis and treatment, and somehow that needs to be characterized in a measurement context. There are sort of inherent kind of uncertainties associated with that diagnostic process. There are uncertainties about the diagnosis itself. There's uncertainties around the harms and benefits of treatment. There's uncertainties about, potential harms associated with just information gathering, tests that could potentially be harmful in some way. And so all of that sort of needs to be characterized in our measurement activities. In chapter 3, they talk about sort of the purposes of measurement, and one of them being to support the development of pathways. And oftentimes the measures that are being developed are reflective of very sort of complex pathways. And that's not typically how we sort of do measurement in terms of complex pathways, but that's certainly part of what is involved in diagnostic performance measurement. They talk about the importance of team-based care, and again, that has implications for measurement related to attribution. There's a lot of, as with all measures, there's IT challenges, but there are particular challenges in diagnosis around tracking diagnostic tests, tracking referrals that are challenging for the implementation of some measures. And then finally, there's a lot of emphasis on the work system, and we're going to return to that theme again, where characterizing the work system is really essential to establishing, the validity of the measures that could potentially be developed. Next slide. So the NQF report sort of, builds on this IOM document and looks at sort of the different domains that could potentially serve as a measurement focus. And I think the telling result of this sort of document is described in this table, which is that there aren't that many measures that really focus on diagnostic performance, and the measures that exist tend to really focus on, a few of the domains, diagnostic efficiency in particular, which often kind of refers to timing issues around, did you receive a particular thing in the time that's prescribed, by guidelines. So lots of opportunities for new measure development and lots of gaps to be identified that are well described in this analysis. Next slide. So they've kind of identify what they felt were the highest priorities that result in significant patient harms. And this idea of missed subtleties, this was exemplified in the case study where we're usually dealing with not the normal presentation. It's sort of often an abnormal presentation. It's those subtle cues, that are missed in a lot of the different circumstances. Communication failures. Again, this is a team-based effort, so communication is central to high performance. Information overload is something that a lot of the measures seek to address, and we'll talk about some of the machine learning type of approaches that people have adopted to try to address that. And then really patience being central to the information gathering process. And diagnostic performance measurement is sort of measurement, almost on steroids. It's like every challenge and issue that exists for quality measurement and other domains is magnified in the challenges with diagnostic performance. And so it really is going to require a large communal effort in order to address it. Next slide. We mentioned that AHRQ had a sort of summit, and they published the findings from their analysis in the journal. Next slide. And they sort of identified what they felt like were the primary purposes, why we want to measure diagnosis. So part of it is we just want to know how many errors there are, and oftentimes there are a lot more errors than we realize. But the fact that we don't have measurement for it, we tend to underestimate how many errors there are. Then once we've identified where there are performance gaps, then we need the measures to help us figure out why these are occurring and what could be done. And then we want to be able to assess those interventions and see if they're working. So this is kind of just emphasizing, the importance of developing these measures of diagnostic performance. Next slide. And then the challenges that they've identified, again, are really about, there's always going to be sort of data gaps, but we'll talk about how the data gaps are particularly challenging with diagnostic performance. And then because we're dealing with systems and trying to understand workflows, understanding what actually is contributing to the diagnostic performance challenges can be very, very difficult. It involves a lot of sort of task and work analysis, observational techniques, which are not typically used in measure development. And then the kind of the evidence base for the effectiveness of interventions is somewhat lacking, which again presents some significant challenges. Okay. Next slide. Okay, so just sort of to summarize, with diagnostic performance, it's diagnosis sort of spans the full sort of spectrum. It's both a safety matter, but it's also a quality of care matter. It involves everything from wellness, to chronic conditions, and so it covers the gamut. The diagnostic process and outcomes are very conceptually complicated. The process itself is very iterative and has a significant sort of cognitive component. The outcomes are often uncertain. Not only is the diagnosis uncertain, but the impact of a diagnostic performance gap is uncertain. Sometimes it might matter a lot, and sometimes it might matter a little. Um, and so that often sort of is determined by what the underlying condition is. There's a significant challenge with sort of demonstrating validity. Partly that's because the evidence base available for diagnostic performance measures is more limited. There are fewer guidelines to go on, and also just establishing causality is a challenge, because you're sort of attenuated from the outcome by the the moderation of the treatment. And so there's not a lot of sort of peer-reviewed literature that could be used oftentimes to support the development of a quality measure. And then this issue of ownership is a particular challenge with diagnostic performance. So part of it is, where does diagnosis happen? It could happen in primary care, it could happen in the ED, it could happen in the inpatient hospital, but primary care has lots of responsibilities, lots of things that they need to address. So how much burden can you put on the primary care setting to look at diagnosis, particularly for these less common presentations? ED, they certainly do a lot of rapid diagnosis, but oftentimes the ED, the goal is to get people stabilized and transferred to the sort of the appropriate setting. So that seems like a more significant priority than a precise, accurate diagnosis. Um, there are issues, with registries. Registries are a potential data source that could be used to improve diagnostic performance, but registries typically cover when the patient already has the condition, not usually the population that is particularly at risk for the condition. That's that kind of stage B population. And so, how do we create registries that could be useful? And again, the comment earlier about how diagnosis is happening more and more outside of the brick and mortar sort of context. So a lot of challenges. So what can we do? Next slide. So we mentioned the importance in both the NAM definition of diagnostic error, the communication to the patient, and the recognition that the patient is really sort of central to this whole sort of effort. They are essential part of the solution. So although we always want to engage patients in our measure development, and we often talk about patient centered care and the like, but with diagnosis, all of those things again sort of are emphasized. So part of what needs to happen is we need better measures of the diagnostic experience from the patient's perspective. But even if you're developing a measure that's not specifically focused on the patient's perspective, you need to be able to incorporate that perspective in your measurement, because again, explanation to the patient is part of what makes a good diagnosis. And so the ability to explain to the patient the diagnosis should be part of the measure development process. There are often sort of patient preferences that potentially need to get incorporated. This is often the case where the diagnostic process involves, uh, information gathering activities where there's a risk involved. And so it seems evident that the patient ought to be not only aware of that risk, but have some say in terms of their sort of willingness to accept that risk. Um, so, so both, having measures of the patient's understanding of the diagnosis and engaging the patient in the measure development process are two sort of central best practices. Next slide. Benefit versus burden. So typically when we talk about benefit versus burden, we're talking about sort of the costs associated with everything that's involved with a measurement. So from the clinician or the facility's perspective. So measurement always involves burden. So it's the burden to collect the data, the burden to report on the data, the burden to act on the data. And usually there's not necessarily a very well thought out calculus to ensure that those burdens are sort of offset by the potential benefits. So we want to be able to focus on those areas where a quality deviation, really can have some significant benefit, to the patients and to the system. And that will support development of our quality measures. But more than that, there is often sort of a focus when we're developing quality measures on, the scientific acceptability aspect. So the reliability and validity, and those things are critical and important. But oftentimes, the sort of the implementation side, which might have to do with the feasibility of the data collection or the usability of the data once it's collected and it's reported, tends to be sort of thought about afterwards. And I think with diagnostic performance is particularly important not to do that. To make considerations of feasibility and usability sort of concurrent with assessments of scientific acceptability. And how one, does that is for feasibility, you really have to understand sort of the workflows involved with data collection and data and with data use. And so measure development with diagnostic performance involves a lot more of that kind of thinking. What actual roles are we creating? What tasks are we creating? What kinds of collaboration are we requiring? Thinking that through, both again, not only in terms of collecting the data, but then acting on the data. Once it's been reported, has an equal role to play in the sort of the justification for measurement as our traditional focus on things like reliability and validity. Next slide. Another challenge with developing measures of diagnostic performance is there tends to be sort of this process in mind of we have data, then that data is used to generate evidence, and that evidence is used to support a measure. But in diagnostic performance, that sort of evidence base often is not necessarily available. And the data that one would use to generate that evidence base often is not available. So in some ways, the process gets reversed, where it's almost about creating a measure and then having some sort of a process of using that measure to generate some evidence, which then establishes the business case for the data collection. And so it's a little bit kind of backwards thinking in terms of how we usually think about measure development. So it's really important when you're developing a measure of diagnostic performance to have a little bit of a roadmap in mind about how this is going to evolve over time, how the measurement will be used in maybe a quality improvement kind of context in order to generate some evidence, which then can be used to establish a business case for data collection, which then can be used kind of conversely then to reinforce the evidence and then eventually sort of be used in a measurement. So that's why we kind of titled this as being a journey more than a destination, because we have to sort of think through how this process is going to work, which is sort of an added complexity of measure development in this context. Next slide. And then there are kind of two sort of related issues here. One is that diagnostic performance often relies on data which is not as readily available. And so it's not typically in structured fields, and even if it is in structured fields, it's not reported with the degree of specificity that we need in order to be able to appropriately characterize, the diagnostic performance. And so there are evolving solutions to this, and NLP is certainly one of them. But that sort of presents its own challenges. It tends to be the most sort of useful when we're dealing with things like pathology and radiology reports, which tend to be a little bit more structured in terms of their narrative than other kinds of textual fields. But there has been some success in using NLP to identify things like signs and symptoms and even some sort of social determinants that could potentially be in the notes. But this again is going to be a journey where maybe we start with NLP on things that are more structured. For things that are less structured, maybe we try to intentionally structure them, so at least the narrative is structured in some way that makes the NLP more consistent and performs better. And then maybe eventually that kind of structured test evolves into a structured field and a structured code that could be used in a more traditional ECQM. But again, that's sort of the data journey mapping that needs to happen. The other thing that is sort of unique about diagnostic performance, again, is that often the scientific basis that we would like to see has to be kind of developed at the same time as the measure. Just as the data kind of needs to evolve, the evidence also needs to evolve. So one of the practices that is supporting this is the kind of the simultaneously development of measures and quality improvement artifacts. So like a measure and a kind of clinical decision support artifact, and develop them kind of simultaneously. And so they mutually support each other. So the measure can rely on the quality on the CDS to help the clinician perform well on the measure, and adoption of the CDS can be used as a way to improve performance on the measure, which supports the validity determination of the measure, and it kind of evolves sort of simultaneously. And that kind of simultaneously development of both quality measurement artifacts and quality improvement artifacts needs to happen at the same time, more so for diagnosis than in other kinds of settings. Okay, so just to kind of wrap up, and then we'll take some questions. But again, diagnostic performance measures have all of the same challenges as traditional clinical quality measures, but to a much greater degree. Structure probably matters quite a bit for diagnosis. Things like the availability of genetic testing, or the availability of a clinical decision support, or the availability of an IT system that can track, referrals, probably matters a lot to diagnostic performance, and could be a major sort of focus area for diagnostic performance measurement. PROMs, patient-reported outcome measures, other kind of measures of shared decision making play a really critical role in diagnostic performance measurement. And implementation needs to be considered from the very beginning of the life cycle. So the feasibility and usability considerations really are mutually supportive of the validity demonstrations. And finally, quality measurement, quality improvement, again, have to be developed in parallel. And one thing that's really evident with diagnostic performance is there needs to be a significant emphasis on learning and the development of sort of tools and artifacts that support learning. Diagnosis is, again, has a big sort of cognitive component to it. And so, again, the development, I think the measures are going to be more valid if they're developed simultaneously with the means and methods of reporting the information back to the clinicians in a way that supports learning. And those things are going to be mutually supportive. So I will stop there and see if there's any questions.
Great, thank you so much, Jeff. So we encourage people to submit questions through the Q&A chat. We've received some to date, and we look forward to more going. So we did have a question that came in asking if you could explain a little bit further the meaning of driving by measures driving the scientific basis for better diagnosis.
Sure. I mean, it's so kind of conceptually speaking, when we talk about the scientific basis for measurement, we're sort of describing kind of a should sort of circumstance. So that there are behaviors that the clinicians who perform well in diagnostic performance, there are behaviors that they do that clinicians that don't perform as well on diagnostic performance don't do. And so usually when we do a validity demonstration, that's kind of what we're seeking to show, that we can identify behaviors that good performers do that poor performers don't do. And because we want to be able to demonstrate under validity that people can respond to the measure in a way that's appropriate. They can respond by changing their behavior in a way that changes their performance on the measure. And so that's typically what the scientific evidence, seeks to establish, that there both are behaviors that can improve performance, and that there are some that exhibit those behaviors and some that don't. But that demonstration of should, there are behaviors that people should be able to demonstrate, also implies can, that that they actually can implement those behaviors. And so if there's not a can, it's really hard to demonstrate the should. And so the idea is that if you simultaneously develop the can, which is the feasibility and usability artifacts, then that supports to a greater degree the should. And so that's sort of the conceptual basis of the argument that feasibility and usability ultimately support validity determinations.
Great, thank you. We have another question that came in, and the question is, how do you balance the over versus under diagnosis in CQMs around diagnosis? Introducing more diagnostics or faster access has potential positive or negative consequences. How to balance these with CQMs around diagnosis?
Yeah, and that's really a critical question that comes up frequently, where there is some sort of diagnostic, it's like an imaging test or something, that has the potential to be overused because it actually involves some harm. It exposes, the patient to radiation. And so you're concerned about overutilization. But at the same time, if that particular diagnostic test is performed underutilized, then you're missing you're missing diagnoses that potentially result in patient harm. And so the effort to address that is trying to develop sort of these balancing measures. So if you underutilize, then there's a negative consequence of subsequent diagnoses that were missed. If you overutilize, then there's a subsequent consequence of low yield and subsequent harm. And so a lot of the effort has been trying to develop these kind of sets of measures that are intended to be used simultaneously. But it's the simultaneous part that's the hard part, right? So how do you, as a clinician, how do you use measures simultaneously? And so this is where it gets kind of complicated. There's a couple of potential solutions. One is you could think about trying to form it in some sort of a composite where performance on a particular measure makes the composite go up, but then when the balance starts tipping the other way, then the composite sort of reflects a downward performance. But that kind of composite would be very complicated. And how do you weight such a composite? And there are people that are using machine learning to try to come up with sort of the optimal weights of these kinds of balancing. But I think it's a work in progress. And we'll have to see how usable they are. And so that's again, the importance of really working with the clinician population who would be the potential adopters and users of a measure like that, to make sure that it is usable and they know what to do, if their performance is relatively high or low.
Thank you. So this is, I think, more of a comment, but something that we received, which is clinicians would benefit from tools that enhance differential diagnosis, especially for zebra diagnosis and testing. ML AI are dependent upon the record, but a F2F patient encounter captures many subtleties that may not necessarily hit the record.
Yeah, and I think that's a really important observation when we think about measurement and sort of the relationship between measures and the availability of tools like that. It could be that what we really need to do, when we first started developing quality measures, there were a lot of structure measures. There were things like volume and things that were used, and then we kind of got away from them. We developed a lot of process measures that were based on guidelines and things, and then there was a big emphasis on outcome measures. But outcome measures are challenging in this context, again, because of the uncertainty and the association with harm, and and then there's all these tools that really, again, this is a cognitively complex and a data complex problem. And so it could be that from a measurement perspective, we need to think more about good structural measures that say, are you using tools that have been well tested and validated, and maybe that's what the focus should be. Because differential diagnosis tools, pretest probability tools, there are all sorts of things that are under development that have to be sort of incorporated into our measurement, sort of, the way we think about measurement.
Great. Thank you all, and thank you for your questions. I want to leave us enough time to go over a couple of announcements. So we wanted to let you know that in case you missed it, our November info session on CMS Measures Management System Blueprint version 17 updates is available on YouTube. We also wanted to let everyone know that on February 23rd, we will be having an NQF presentation on their latest report, Building a Roadmap from Patient-Reported Outcome Measures to Patient-Reported Outcome Performance Measures. So just wanted you to be on the lookout for invitations coming about the February 23rd info session. And then wanted to let everyone know that CMS Merit is opening soon. So the CMS Measures Under Consideration Entry Review Information Tool, which we refer to as CMS Merit, will open for measure submissions for the 2022 MUC list on Friday, January 28th. And CMS Merit will remain open until Friday, May 20th. So it is opening on Friday the 28th, closing on Friday, May 20th. And then we wanted to let you know that please visit the pre-rulemaking website to stay up to date on all things pre-rulemaking. And included in the MMS info session on February 23rd, there will be a feature of a brief demonstration of some of the new aspects of CMS Merit. So included in the NQF presentation, prior to that, we will be doing a brief demo letting people know about some of the updates to CMS Merit. And I believe here we have the contact information. So if you would like to follow up with us, you can see my contact information here, as well as the contact information for our contracting officer. And I wanted to thank everyone. And oh, it looks like we have, so we have one question that came in late and we have a couple minutes. Jeff, are you okay to answer one more?
Sure.
So we have one more question before we exit, which is, how can we measure misdiagnosis if we don't know who should have been in the denominator? So I think that's just one last question for us to discuss before signing off.
Yeah. And I guess the short answer is we need to figure that out. Like we need to figure out who the at-risk population is, and it's something it's not like cut and dry, right? Because there are sort of degrees of risk associated with a particular condition. So I think the folks that are looking at this, for example, if you're concerned about a misdiagnosis, for AMI, then you look at a bunch of signs and symptoms for people that are potential candidates for AMI, and that could be too big or too small, and so trying to come up with kind of the optimal sort of specification for that, where you don't capture too many people, but you capture there's sort of the sensitivity specificity trade-off, which is inherent in all of those kind of diagnosis measures. That's part of what needs to be investigated, explained, articulated, and somehow optimized. But it's a good question, and it's definitely one of the major challenges.
Great. Well, I want to thank you all for attending and thank Jeff for this presentation. Hope everyone has a great rest of their day.
Thank you.